This film is intended for eye surgeons for training and education purpose. Viewer discretion is strongly advised, not suitable for children. This is Dr. Magan Patel, Patel Eye Care and Laser Center, Bhuj. In this video, I am going to show you an effective technique for the management of the morgagnian cataract. Let's look at some peculiarities of the morgagnian cataracts. The nucleus is hard and compacted and almost always leathery in nature. The epinucleus and cortex are fully liquefied and ooze out during the CCC, such that by the time we start phacoemulsification, the capsular bag is empty except for the nucleus. Therefore, the protective buffer of the epinucleus does not exist, and perfect control of the hands and probe is essential. Fibrotic patches in the anterior capsule make CCC challenging. However, the stiffening of the capsule also in our favor, as the PC does not trampoline during phaco as seen in empty capsular bag. Mature cataract speckle calcified spot on the anterior capsule, liquefied cortex, a small dense amorphous leathery hard mobile nucleus seen in this case. As I puncture, liquefied cortex material ooze out from the bag. I aspirate with the cannula. Here you do not inject any fluid within the bag, otherwise bag gets extended. And because of there is no counter support, we can use either forceps or hydrocannula. I prefer hydrocannula because I get better control with this hydrocannula, and you can use your uterata forceps also. We cannot use cystitome because there is no counter support of the nucleus. It is very difficult to tear a capsule in presence of the mobile nucleus, so I avoid the use cystitome and I use hydrocannula. No need of hydrodissection because all the cortex material comes out with the puncture of the CCC. Here we see clear-cut mobile nucleus which is leathery in nature. I prefer direct chop in this case. Chopping is challenging because the nucleus is likely to take stress on the PC and zonules. Let's begin the case. I prefer horizontal chop. This is my phaco setting. Power is 30%, aspiration flow rate is 30, vacuum is 600, bottle height is 90 centimeters. Here I use horizontal chop. My goal is divide the nucleus without causing any stress on the rhexis and zonules. I prefer horizontal chop. I buried the phaco tip with the stiff angle, and here you see I create a crack with the mechanical force. Against I bury the phaco tip with a stiff angle, and against I lateral separation of the piece. And here we need little more compressive chop. So because of this mobile nucleus, it needs some compression and emulsification at the anterior plane because we always protect the posterior capsule. And here you see the start remove the phaco fragment, and this is for fragment my phaco setting. And I use torsional in this quadrant removal and try to emulsify the nucleus piece at the anterior plane because posterior capsule is exposed, so chances of PC rent is high. And specifically take care to remove the last piece, and you change a little bit your phaco setting or the lower side, and use appropriate amount of the visco dispersive to protect the endothelium. And there is no cortical material, so hardly left some fibers is there. So this kind of cataract you keep in mind problems like corneal endothelial damage, zonular damage, posterior capsule rupture, nucleus or cortex drops. So take home message by this video is capsular staining must. Cortical fluid drainage is must. Waxes not with cysterectomy. Use direct chop. And implant the IOL in your choice. Thank you for watching this video.